I think, relevant and exciting program ahead of us. So, yeah, we look forward to that. Now, before I introduce our first speaker, just a quick reminder to everyone, especially those who might be new, that this is a weekly training meeting that runs from 4 to 5:30 every Monday. Typically, we would have a talk followed by some case presentations. Sometimes we do a couple of short talks. So the idea is really for everyone to get involved, make their inputs, their comments, that we can all teach and all learn, as they say. So everybody can learn from everybody. It is not necessary to put your name and your MP number in the chat box, because at the top of the hour, we will put a link in the chat box for you to register your presence, which will then be sent to the HPCSA for your CPD points. These videos are also recorded, so you will be able to access them afterwards. And you can just email Mrs. Melanie Davids at UCT. We'll put the email address in the chat box now. If you want access to the recordings, we are in the process of finalizing the Blood SA website, on which all of these are being loaded as we speak, as a matter of fact, and you'll soon be able to access all of these once that has been completed. So, if I may ask those who are not speaking to just mute your microphones. I see some microphones that are still on. That would be great. Thanks very much. And let's get going immediately. So we're fortunate to have, I think, for the first time as a speaker, but I must say I did miss one or two deep dives during times when I was either traveling or on holiday. But I think, Elise, this is your first time speaking here. Is that right?
That is correct.
Great. So Elise, now again, I hope I get the pronunciation right. Shapkaits, or how do you say it?
Yes, no, that's correct.
Elise is a consultant hematologist at Charlotte Maxeke, Johannesburg Academic Hospital. She's an associate professor at Wits University, and she's got a special interest in diagnostic hematology and anticoagulation of pediatric patients and pregnant patients. She has published widely on these, and also together with other experts in the fields, and I've been fortunate to work with Elise and Prof. Barry Jacobson on some work on thrombosis in COVID that we are putting together at the moment. And I know Elise has taken a leading role there as well with Prof. Jacobson. Now, just from my own experience, both in private practice and in the public sector, questions on thrombosis, venous thromboembolism, hematological issues in general in pregnancy is very common. And we are often confronted with patients who might have had previous thromboses or a thrombophilia or whatever other hematological condition, who wants to fall pregnant or wants to fall pregnant again after a previous episode, perhaps during pregnancy. And the question to the hematologist is always to help the obstetrician plan for that pregnancy. So I would say for the couple of years that I spent in full-time private practice, this must have been one of the more common types of referral that I received. And even today, I think in my private practice, coagulation-related issues make up about 1/3 of the work that I do. So really relevant, interesting, and important stuff. So Elise, we look forward to listening to you, and I will introduce our other speakers just after, but the floor is all yours, and I see we've got 81 people in the room already, so I think we can certainly get going. Thanks, Elise.
Thank you for that kind introduction. Okay. Here we go. All right, these are my disclosures. Okay, so good morning, everyone. Good afternoon, everyone. Firstly, by way of introduction, pregnant women have a 4 to 5 times higher risk of developing thrombosis compared with non-pregnant women of the same age, with an estimated incidence of thrombosis of approximately 1 to 2 per 1,000 pregnancies. A hypocoagulable state, venous stasis, and vascular damage at delivery all contribute to this increased risk. Roughly half of pregnancy-related VTE episodes occur during pregnancy, and the other half during the 6-week postpartum period. We know that thrombosis is the direct leading cause of maternal mortality in the developed world. In South Africa, our major cause of maternal death continues to be infection-related. But what is worrying is that the rates of pulmonary embolism in South Africa in the past 3 trienniums have not changed. A maternal death is a devastating event with far-reaching consequences for the woman's family and community. VTE also has significant morbidities. So the first topic I'd like to discuss today is the risks of anticoagulants during pregnancy. So based on available safety and efficacy data, low molecular weight heparins are the first choice in pregnancy. Unfractionated heparins can also be used, but these require frequent PDT monitoring and are associated with a higher risk of heparin-induced thrombocytopenia, reduced bone density, and osteoporotic fracture. It is important in women who are receiving long-term therapy with vitamin K antagonists such as warfarin or the DOACs are counseled about the fetal risks of these medications before conceiving. So we know that warfarin is not recommended in the first trimester, and this is owing to the highly variable rates of warfarin embryopathy. The average that these have been reported at is about 3 to 6%. This is characterized predominantly by nasal hypoplasia and stippling of the epiphyses. This most frequently affects the axial skeleton, the proximal femur, and the calcaneus. And this occurs following exposure between 6 and 12 weeks gestation. So lower doses of warfarin of less than 5 milligrams have been associated with a lower rate of complications, but a dose-dependent relationship has not been found in all cohorts. And the safety of first trimester warfarin of less than 5 milligrams still needs to be confirmed. And this requires discussion with the patient who is taking first trimester warfarin. So in women who are taking warfarin and wish to conceive, it's important to advise women to perform a pregnancy test, and this often may require frequent pregnancy tests, and then to substitute her warfarin with low molecular weight heparin once pregnancy is achieved. And this should be advised prior to 6 weeks. Please keep in mind that this presentation is about women with VTE or the prevention of VTE and not mechanical valves. The concern, however, with taking warfarin early on in the first trimester is that it doesn't obviate the risks of CNS abnormalities, miscarriages, or stillbirth. And these have been described following warfarin exposure during any trimester. CNS abnormalities are often described together with warfarin embryopathy, but they appear to be rare and occur at a rate of about 0.7 to 2%. What about the DOACs? Because increasingly, women are now using DOACs instead of warfarin as long-term therapy and are falling pregnant on DOACs. So the management of women who are receiving long-term therapy with DOACs is controversial, and this is because there's limited data. So at the moment, what the International Society of Thrombosis and Hemostasis advise is that any woman who wishes to fall pregnant, any woman who is pregnant, or any woman who is breastfeeding, that the DOACs are contraindicated. But if we actually have a look at the data that we have available to us, so there's pooled data that is available of 576 cases of DOAC exposure in pregnancy. The majority were receiving rivaroxaban, and we have outcome data on 304 pregnancies. And this outcome data is actually very reassuring. So the rates of teratogenicity in this pooled data was 2 to 4%. They were very variable and they didn't follow a distinct pattern. And the rate of miscarriage was 22%, which is similar to the risk in the overall population. So guidelines currently suggest that if a woman's on a DOAC and she wishes to conceive, that she should be switched either to warfarin or to low heparin before conception. But a more simple and practical option that needs to be discussed with the patient is that she continues with the DOAC until pregnancy is confirmed and then directly switches to low molecular weight heparin. So low molecular weight heparins are the treatment of choice or the drug of choice for the treatment and prevention of VTE in pregnancy. However, they do have few side effects. In addition to the pain and out-of-pocket costs, bruising is common. Skin reactions are higher in pregnant women as compared to non-pregnant women. The majority of these have been described with nadroparin, and as such, the low molecular weight heparin of choice in pregnancy would be enoxaparin. These skin reactions are delayed type 4 hypersensitivity reactions at the injection site. And as can be seen in this image with consent from the patient, it shows erythematous lesions at the injection site, which were tender and pruritic. These skin reactions may improve with a class switch to another low molecular weight heparin. And if there is cross-reactivity with the low molecular weight heparins, fondaparinux can be considered. Please keep in mind that the data about fondaparinux in pregnancy is limited, and its use in first trimester is not recommended. HIT is a very rare complication of low molecular weight heparins in pregnancy. And lastly, the risk of major bleeding with low molecular weight heparins is similar to those patients who are not receiving prophylaxis. Moving on to the treatment of VTE. So if a patient presents with a venous thromboembolism in pregnancy, what are the available low molecular weight heparins to us in South Africa? So in South Africa, we have enoxaparin available and we have nadroparin available. Experience with bemiparin is very limited in pregnancy. How do we initiate treatment? So treatment should be initiated with a weight-based adjusted dose, and then the dose should subsequently be adjusted according to anti-10A levels if you have those available to you. There is limited evidence to guide a once daily or twice daily regimen, but a twice daily approach is the more rational choice pharmacokinetically. So what about anti-10A monitoring? So the reason we advocate anti-10A monitoring in pregnancy is to ensure adequate low molecular weight heparin dosing. And this is because the pharmacodynamics of low molecular weight heparin are altered as a result of the increased volume of distribution and enhanced renal clearance. And this can be nicely seen in the figure from the study by Bailey et al., which showed that 15% of women required dose adjustments in the second trimester, and a subsequent 30% of patients required dose adjustments in the third trimester in order to achieve a target anti-10A. Current guidelines, however, suggest not to monitor anti-10A levels. And the reason is because there's no data to support it, because the studies to date have not demonstrated an improvement in efficacy and safety outcomes with regular anti-10A monitoring. Practically, anti-10A monitoring also has several limitations. These assays are relatively expensive and are not routinely available. Also, the timing of the assay is important for accurate interpretation. The expert opinion, however, is to monitor anti-10A levels in women who are at high risk until further evidence becomes available. So what you should advise your patients is to inject in the morning so that they reach that 3 to 4 hour peak level for anti-10A blood sampling during office hours. The anti-10A can be done 1 week after starting low molecular weight heparin and thereafter monthly or per trimester. How long do we treat a venous thromboembolism in pregnancy for? So this depends on the risk of recurrence. So if we have a look at the data from the RET registry, the 2-year risk of recurrence in a woman who had a pregnancy or postpartum related thrombus is 3.3%. So this data suggests that limited duration anticoagulation is appropriate for most women, provided you follow up and you take into account personalized risk assessment, personalized risk factors. So what is recommended is at least 6 weeks postpartum for a minimum total duration of 3 months. Moving on to a discussion now about the prevention of thrombosis in the antepartum period. So pregnant women and their physicians are faced with difficult decisions of weighing the risk and benefit of anticoagulation during pregnancy. The guidelines that we have available to us are many, but these are based on expert opinion rather than high quality evidence. And they all suggest various approaches. And so it's very difficult, particularly given the competing risks and challenges of anticoagulation. And so what is recommended is that each woman who sits in front of you is individually risk assessed, and that we engage with our patients in shared decision-making and take into account their values and preferences. So if you do choose to go with prophylactic anticoagulation in pregnancy, particularly where there is evidence for this, such as in the high-risk pregnancies, so those would be someone with a previous unprovoked or pregnancy or estrogen-related VTE, or a woman with a high-risk thrombophilia, such as a homozygous factor V Leiden or prothrombin gene mutation. You need to institute low molecular weight heparin as soon as pregnancy is positive, as the risk of VTE is similar across all 3 trimesters. The optimal low molecular weight heparin dose is currently unknown. And this is currently being investigated in the high-low study. These results are anticipated in 2022, and this will hopefully provide us with the high-quality data that we need in order to manage these high-risk pregnant women. So most centers will use a standard fixed low dose of low molecular weight heparin as prophylaxis in women. Most women fall into the weight range of about 50 to 90 kilos, and they will use 14 milligrams. But what we've seen in the literature is that this fixed low dose in high-risk women is associated with a high risk of recurrent VTE at rates of about 5 to 8%. And so what's recommended is either an intermediate dose, which is a half a therapeutic dose, or anti-10A adjusted monitored low molecular weight heparin during pregnancy. In women who are at intermediate risk for thrombosis, so those are women with a single provoked thrombosis related to a transient risk factor, or with lower risk or intermediate risk thrombophilias, such as protein C and protein S deficiency, and heterozygous for factor V Leiden and prothrombin gene mutations, or women with medical comorbidities. In these women, a prophylactic dose is more suitable. Alternatively, clinical monitoring. What about in the postpartum period? Well, in the postpartum period, if a woman is high risk and she warranted antepartum prophylaxis, low molecular weight heparin should be continued for at least 6 weeks. In women who are at intermediate risk, the recommendation is to continue for at least 10 days. And this is because the risk of thrombosis is highest within the first 2 weeks postpartum. In women who are at low risk, who have an additional 2 risk factors, postpartum thrombotic prophylaxis should be continued until discharge. Lastly, I'd like to touch on some practical considerations around delivery. I think the most important thing with regards to delivery is that management of delivery should be considered by a multidisciplinary team in order to minimize the risks of bleeding, hematomas, and thrombosis. So in women who are at high risk, a scheduled delivery is preferable in order to minimize the duration without anticoagulation. It's important to instruct all women to stop low molecular weight heparin upon the first signs of labor. The last injection before the scheduled induction of labor or elective Caesar should be within 24 hours if the woman is receiving a therapeutic dose, within 12 to 24 hours if she's receiving an intermediate dose, or within 12 hours if she's receiving a prophylactic dose. And if we respect these time intervals, the majority of women who are receiving low molecular weight heparin should be able to safely receive neuroaxial analgesia. Post-delivery, low molecular weight heparin can be started 6 hours after removal of the catheter. The cannula should not be removed within 12 hours of the most recent injection. Importantly, neurological monitoring is mandatory for a minimum of 12 hours and ideally for 72 hours after neuroaxial blockade. In the postpartum period, we can then restart anticoagulation, provided that there's adequate hemostasis after 6 to 12 hours. In the postpartum period, the reported rates of bleeding with low molecular weight heparin are low, and as such, low molecular weight heparin is the most practical option to continue with in the postpartum period. A reminder to continue with it at the non-pregnant dose. So that brings me to the end of this short presentation. And the key messages I'd like to leave you with is that firstly, the recommended approach is to individually risk assess each patient and to engage our patients in shared decision-making. Low molecular weight heparins are safe and effective in pregnancy for the prevention and treatment of VTE, but there are still important gaps and high-quality research in this area should be a priority. The management of delivery needs a multidisciplinary approach in order to decide on the most ideal delivery plan. Neuroaxial analgesia can be administered in most patients, provided the time intervals are respected. And finally, it's important that treating doctors counsel all young women who've previously had a VTE about the associated risk factors, contraception, and future pregnancies. I'm very grateful for your attention. Thank you.
Elise, thank you so much. I think that was really an excellent presentation to focus on the key points that are relevant in this type of setting. So that's really great. I also want to just remind everyone, you can put your questions in the chat box, or we can have some question. We'll definitely have a Q&A session towards the end. If anybody has a question straight away, while our next speaker, Dr. Rimtula, is uploading and sharing his screen, we can take it now. Otherwise, we'll move to the next one immediately. Are there any? I don't see anything in the chat at this point. Anybody want to put up their hands? Elise, maybe just sort of one general question. If you've got a patient with a thrombosis during pregnancy, what kind of workup do you do? Let's say it's someone with no previous history of thrombosis at all. Do you do any workup whatsoever?
So on further history, we'd like to know about the obstetric history. We'd like to know whether or not there's a history of recurrent miscarriages or intrauterine fetal deaths or preeclampsia that may suggest a history of antiphospholipid syndrome. And then with regard to the thrombosis, we'd like to know about a personal history of a previous thrombosis and any family history, if there are no other related causes. We prefer not to do the workup in pregnancy because pregnancy alters the interpretation of the results. And so we may plan to do that because it's not really going to adjust our management. And so we rather prefer to bring the woman back 6 weeks postpartum, and at that time to then, if necessary, do a workup for inherited thrombophilia and antiphospholipid screen as part of the counseling for subsequent pregnancies.
I'm very glad you mentioned that. And I want to make this as a general comment as well. It's one of the most common problems I see is patients who've had a thrombophilia workup done at the wrong time point. Let's say either on anticoagulation or during an acute event. And I'm thinking specifically about not about the genetic factors so much because they will be unchanged, but the reality is that many of these will be low if you test them at the wrong time points, and you have to then repeat them. In my practice, delabel about 9 out of 10 patients that are referred to me with protein S deficiency, for instance, because it's done at the wrong time. And when I do it, when the patient is off anticoagulation and there's enough time that is transpired between the episode and the testing, they all have normal protein S levels, almost all. And those who did have really low ones usually had strong family histories as well. So I think it's a very important point. Thank you. We've got some more questions now in the chat. There's a question on therapeutic low molecular weight heparin that has breakthrough thrombosis. Is there any additional anticoagulation, i.e. antiplatelet agents or an inferior vena cava filter? Elise,
yes, so I think it's important to go back and actually have a look at that compression ultrasound and see what you mean by breakthrough thrombosis. Is it possibly not just residual thrombosis? to also have a look at the timing of the event of the thrombosis. When did this woman have the thrombosis relative to pregnancy? So we know that if she has a thrombosis and falls pregnant within 3 months, she has a very high risk of having residual thrombus or extension of that thrombus. And I wouldn't actually add anything in this case, but I would extend the duration of her treatment. I don't know if you'd like to add anything to that, Prof. Lowe, if your management would differ.
Look, if it's a real, let's say, a repeat episode or a new thrombosis in a different area, or a thrombosis that's extending, I must say the way I've done it so far is to then actually monitor, and in fact, anti-10A levels, and ensuring that the patient is at a therapeutic or whatever target we're looking for level. Also to make sure that your doses are correct. If you're giving a prophylactic dose or you're giving a dose for a so-called low-risk patient, that might be a patient where you want to move to a higher risk patient dose. But practically speaking, I typically would increase the dose in most patients and ensure that I reach an anti-factor 10A target that is better than whatever I have at that point in time. Don't know, Elise, if you
yes, definitely.
Can live with that.
Yeah, yes. So we do routinely monitor anti-10A levels in our high-risk women. So that would include women who are receiving therapeutic doses of low molecular weight heparin, and we aim for an anti-10A range of 0.5 to 1.
Yeah, that's what I do too, exactly. There's a question from Livingston Dogara. Thanks, Elise, for this insightful talk. What should be the approach in a patient with hemoglobin SC delivered through C-section? We initially placed her on a prophylactic dose of low molecular weight heparin, but now with a C-section before full mobilization, should that continue?
So if you have a look at the Royal College of Obstetric guidelines, which is probably the most lenient of guidelines, they regard patients with sickle cell disease or compound heterozygote sickle cell disease as intermediate risk, and they would recommend that she continues with a prophylactic dose of low molecular weight heparin for 10 days to 2 weeks postpartum. So that would be our recommendation as well.
Thanks. Then Jacques Malherbe from Bloemfontein. Should women planning to conceive be on warfarin? Isn't the highest risk of fetal warfarin syndrome with exposure in the first trimester? I thought that women of childbearing potential should either be on contraception or switch to low molecular weight heparin if they plan to conceive.
So we have a lot of women in our anticoagulation clinic who wish to conceive, and the advice we give them is to frequently test for pregnancy if they wish to conceive, and to present us as soon as they fall pregnant. And then we risk assess them as to whether or not they are suitable for a switch from warfarin to low molecular weight heparin. And we generally are able to switch them before 6 weeks. The highest risk of warfarin embryopathy is between 6 to 12 weeks. The problem is that it's very costly and it's very difficult to give a woman low molecular weight heparin prior to she's conceived, and to ask her to inject herself for the coming months prior to conception. So using this approach, we've had quite a low rate of warfarin embryopathy. I know it's reported as being about 3 to 6% in the literature, but in our center, it's about 1%. And that the highest complication that we actually see with the warfarin, unfortunately, is miscarriage. And so in a woman who is having recurrent miscarriages as a result of falling pregnant on warfarin, we may relook at the situation. I hope that answers your question.
Thanks, Elise. Then there's Sarantha Fulchan that says, thanks for a wonderful talk. This is a real patient we currently have at Inkosi Albert Lutuli Hospital, portal hypertension, pancytopenia, platelet count of 22. I suspect that is fetal growth retardation, current upper segment DVT, delivery unpredictable due to the FGR. Sarantha, if I'm misinterpreting what you're writing, please just put a note in the chat. What would be the ideal anticoagulation now and peripartum?
You require multidisciplinary management. Are you able to optimize that platelet count in any way? because that is always the concern with putting a patient on low molecular weight heparin who's now sitting with a platelet count of less than 50, but the platelet count will need to be optimized for delivery.
At the moment, we are not able to do anything further. The patient is resistant to steroids.
And what anticoagulation is she currently on? Have you put onto prophylactic or therapeutic doses?
Nothing currently. The anticoagulation was stopped because of the platelet count.
And how many weeks is she now?
32.
I'm going to have to ask Prof. Lowe for his opinion on this case. This is a very difficult case.
Yes, for us as well.
It's the platelet count that really is the concern here. And I'd be tempted just to maybe just put onto prophylactic low molecular weight heparin as opposed to therapeutic.
Yes, Sarenta, can I just double check with you? So it's a patient with pancytopenia and portal hypertension. Is this hypersplenism, or does the patient have aplastic anemia?
A hypersplenism.
Okay, so hypersplenism, you might, functionally probably have a slightly higher platelet count. This is a big challenge. You said she's now 32 weeks.
Yes, correct.
And what do you mean by an upper segment DVT? Is that like an femoral iliac vein area?
Yes, iliofemoral.
Iliofemoral vein. Yeah, and you don't get any response, because normally if we put a patient on low molecular weight heparin, we typically would want the platelet count to be above 50. Does she bleed at all with this platelet count?
No.
Yeah.
May I say something? We don't really know the cause for the portal hypertension, or do I miss something? We don't actually have the...
Possibly Bilharzia.
Okay. So it's a form of non-cirrhotic liver cirrhosis, or whatever. What liver?
Yes, yeah.
Yeah, so I think you are...
So there's a couple of factors here. So if there's liver disease, then the question is, to what extent is the clotting negatively impacted by the liver disease, which together with the severe thrombocytopenia will shift her towards bleeding. On the other hand, if she's had a thrombosis in a mesenterium, portal vein, or wherever causing the portal hypertension, plus now an iliofemoral DVT, she's probably at extreme risk of recurrence, a VTE, a pulmonary embolus, and that's going to continue in the postpartum period. So this is, I think, the type of patient that I would probably discuss. This is where I phone a friend, and I would phone one of the experts in thrombosis in the country, like Prof. Jacobson or Pete Wessels or one of those, and or speak to my vascular surgeon and see whether a filter is not an option here.
Okay, and is there any place for fondoparanux?
The half-life is too long. It will increase her risk of bleeding.
Yeah, it's a similar problem. Let's see, is there anybody else in the room? I didn't look I don't know who is in the room. Is Prof. Barry or Pete here? Or anybody else that's got a passion from this, who's from the South African Society for Thrombosis and Hemostasis? But yeah, I think that's what I think I would consider, is to see if we can place a temporary placement of an inferior vena cava filter.
Yeah, absolutely. We will speak to one of them. I just thought this was a really interesting case. It's a conundrum for us anyway.
Very interesting case, Sarenta. Thank you.
Okay, thank you.
Are you part of the clinical hematology team?
No, I'm a maternal fetal specialist at the hospital and Albert Lutuli for the time being.
Brilliant. Nice that you came. Excellent. Good. Thank you. Okay, I think we can move on. These were really very interesting conversations, and it shows how difficult some of these cases can be. And maybe I can just close that part of the session by saying, make sure you always have a friend to phone. I don't consider myself as a thrombosis expert, although I do a lot of the work, but I always have one of the experts on speed dial, that if I get stuck with a difficult case like Cervantes, that I can ask and get their opinion. Good. Thank you, Lise. You've certainly created a little bit of a buzz there with lots of interesting questions. Our next speaker that I'd like to welcome is Dr. Arun Remtula. Thank you very much, Arun, for joining the hematologists today. But as you can hear, there's people from all over. Dr. Remtula is a specialist obstetrician and gynecologist and also lecturer at Charlotte Masheke and Wits Medical School. He obtained his degree from Wits, worked abroad, did his FCP and MEd, and he also won the Gordon Grant Prize for his academic achievements in gynecology. After working in both state and private practice, he moved to the province of Alberta in Canada, where he worked as a senior specialist and later as head of department, associate zone medical director of women's health and chief of surgical services. And then there's a long abbreviation, Arun, that you can explain to us, of the NLRHC of Alberta Health Services. Fortunately, the good news is that he did return to South Africa and is now a fellow in maternal and fetal medicine. Arun, welcome. The floor is yours.
Hi, good afternoon, Prof. Can you all hear me?
We can hear you very well. Thank you.
And can you see the slides?
We can.
Okay, brilliant. So my talk today is on the heart and valves and anticoagulation. And the topic is very contentious in terms of what do you actually use when it comes to these patients. And I'm not here to tell you what to do or that you should change what you are doing. Is just to highlight the things that are out there and what we do in the unit that I run with the help that I get and with from hematology and from general medicine and cardiology as well. So Elise is part of this team. And when we talk about the heart of concerns, we mean the very vital part. And it is a very vital part of what we tend to do and the care that we do offer at our hospital. Now, if you look at this slide, the next slide is to sort of tell you about this team approach. We do not do things alone. And certainly since I came back, we tend to work in a team, and the team approach gives the best care. And this team approach discusses every single case that we have. We sit in a joint clinic, and we certainly get the best results then. And I think the way forward now on would be to do things in terms of team approaches where different specialties hone in to give the best care to the patient at risk. Now, from the unit that I run, as you can see, we from a combined approach, we have published papers regarding the patients that we have seen and our approach to things as well. So it's quite nice to have this unison where you're not a silo on your own, but indeed doing things together, which is the way forward and how it should be done. So in South Africa, maternal cardiac disease is still a major concern of maternal deaths. And this has not changed. And this is from the 7th triennial report. And we still carry the burden of cardiac disease. In fact, after HIV disease, this is the next common cause of severe disease and severe mortality as well. Now, pregnancy is an acquired hypercoagulable state. And this is of great concern because there's a 4 to 10-fold increase in your risk of thrombosis. So how do we run our clinic and what do we look at? We use the maternal risk stratification and we use the modified WHO score. And from that, you can see that every patient with a mechanical prosthetic heart valve certainly is WHO3. Those with tissue valves tend to be WHO2 with a small increased risk of concerns, but we rarely find patients just with the tissue valve alone. They sometimes have concomitant cardiac dysfunction, which will push them down a rung as well. So in fact, we mostly deal with WHO3 patients. Now, risk factors of concern from a patient point of view, and a patient cardiac point of view, as you can see, is maternal anticoagulant use. But that also translates into an obstetric concern, because you have the neonatal outcome is then dependent upon the use of such drugs, but also from a mechanical valve point of view, and because of the concerns that it does generate in terms of the treatment that you need, but also from a cardiac dysfunction point of view, if it is there, the concomitant drugs that you need to use to ensure that the maternal side stays alive. Now, you cannot talk about cardiac valve disease without knowing that the changes that occur in the parturient from a physiological point of view has impact on how we look at the disease state. So the major concern is that pregnancy is a hyperdynamic state, but at the same time, there's a decrease in your TPR, your total peripheral resistance. Accompanied to that is this increase in your fluid volume, in your red cell mass, but also coupled to this is your changes in your respiratory system as well. Besides all of this, the hematological side, which one tends to forget, goes through drastic changes as well. And these changes result in, as we've said, and as you've heard, in the 4 to 10-fold or 5 to 10-fold risk of clot formation, but it also does change immediately 1 hour post-birth. And of course, within the first 24 hours after birth, and these changes can take anywhere from 8 to 12 weeks to reverse. So anticoagulation in the antepartum period is certainly one phase, but it's not really the same kettle of fish in the postpartum phase. And henceforth, the idea of just an antenatal clinic, and we sort of, baby's out, mom seems fine, we forget about things. This needs to translate into better postnatal care. And we do need to have better postnatal clinics where patients are reviewed, within that first week, within the first 6 weeks, and perhaps within the first 3 months after birth, to have an understanding of what's going on from a cardiovascular, but also from a anticoagulant point of view, and especially with the drugs that we tend to use. So what drugs do we use? We use heparinoid drugs and coumarin type drugs. Heparins do not cross the placenta. They do not result in concerns for us. And they are not excreted in the breast milk either. Warfarin does cross, and it causes the warfarin embryopathic syndrome. And you've heard eloquently what it can result in. Now, we tend to use low molecular weight heparins, and we tend to use a drug called enoxaparin. And how it works